Well, hi everybody. Welcome to part 2 of Common Pediatric ECGs in Dr Manny's YouTube Learnshops. And as I mentioned previously, this is for pediatric nurses, or it's for anyone really who's interested in learning about pediatric ECGs. The learning objectives for this session are to look at the electrocardiographic recording paper, calculate heart rate, get you to do a little bit of work, a systematic approach to ECG analysis, and criteria that pertains to a normal PQRST complex, and then review certain selected technical problems. Let's review again. In your knowledge review, we have which of the following is the normal pacemaker of the heart? The normal pacemaker of the heart is the SA node. Which of the following are components of the conduction system of the heart? And the answer is all of the above. Which of the following statements best represents the P wave? Ventricular depolarization, atrial repolarization, ventricular repolarization, or atrial depolarization? And the answer is atrial depolarization. Which of the following statements relates to the sympathetic nervous system? Does it increase heart rate, increase conduction speed, increase contractility, or does it do all of the above? And the correct answer is it does all of the above. Which of the following statements is correct about the normal heart rates? Does a child have a heart rate of 60 to 100 beats per minute if they're older? Does a newborn have a heart rate of 50 to 80 beats per minute? Does an infant have a heart rate of 35 to 85 beats per minute? Or are they all validated and are correct? The correct answer is that a child has a heart rate of 60 to 80 beats per minute because the other ones are potentially slow. Which of the following relates to the parasympathetic nervous system? Does it slow conduction through the SA node and AV node? Or does it just slow heart rate in general? Or are all of the above correct? And the correct answer is they're all correct. Parasympathetic dominance. Which of the following leads are considered standard ECG leads? A, lead 1, 2, 3. B, AVR, AVL and AVF. Are they unipolar and bipolar? Are they all correct? All of the above. Which one? All of the above is correct. They're all standard leads. Which of the following relates to sinus tachycardia? Is it due to parasympathetic nervous system stimulation? Does it have a heart rate of 40 beats per minute? Does it decrease myocardial oxygen demands? Or are none of the above correct? And the correct answer is none of the above are correct. Which of the following connects to atrial fibrillation? Is it chaotic electrical activity? Does it have a rapid irregular rate? Does it have no P waves? Or are they all correct? And the correct answer is they're all correct. All the above are correct. Which of the following correlates to premature ventricular ectopics, contractions, complexes, whatever terminology you like, PVCs? Do they originate in the ventricles? Are they wide in appearance? Do they have an abnormal shaped T wave? Do all of them apply? The correct answer is all of them apply. Now, can you remember the following ECG anomalies? What's this one? They're premature ventricular complexes, but you can call them couplet PVCs because you've got a couple, they're the same, they're together. What about this ECG anomaly? This is supraventricular tachycardia, or SVT. What about this ECG anomaly? You'd probably be calling a code blue, I'd be thinking. This is ventricular fibrillation. This is coarse ventricular fibrillation, because you can have very coarse, coarse, fine, very fine ventricular fibrillation, VF. What about this ECG anomaly? Well, this is, if all the leads are connected correctly, asystole. What about this one? Can you name the following ECG anomaly? It's very irregular. This is atrial fibrillation. And the proper terminology would be atrial fibrillation with a controlled ventricular response. There really isn't a slow or a fast atrial fibrillation, or AF. It's either uncontrolled or controlled. Controlled basically means on medication. Uncontrolled means not on medication. On medication, it does slow down, or the ventricular response does. Without medication, the ventricular response is rapid or fast. Now, it's important to remember that the electrocardiographic paper records two things: time and voltage. Time in milliseconds or seconds, and voltage in millimeters or really millivolts. When we look at the scale details, each big square along the horizontal axis, which is time, is represented by little squares and big squares. Now, the little squares are, on the horizontal axis, 0.04 of a second or 40 milliseconds. And you've got 5 of those, or 25 in a big square, and they are represented by 0.20 seconds or 200 milliseconds. And this allows you to work out how quickly conduction is through a heartbeat or an ECG complex, which becomes important if you want to work out details as to whether it's a normal beat or an abnormal beat. A beat that's affected by conduction details, such as, we'll use the term heart block, but really conduction defects. Or whether it's supraventricular, ventricular, atrial, or junctional. So these are some of the recording rules that I think are important to remember. Guidelines. You always have to check that your paper speed is set at 25 millimeters per second. And if you check that it is set at that, then the small squares are equal to 0.04 of a second, or 40 milliseconds. And big squares are equal to 0.2 of a second, or 200 milliseconds. You've got to make sure that the calibration marker, which determines the size of the ECG, is always set at 1 millivolt, which is the same thing as 10 millimeters. So the recording rules are: make sure that your paper speed is 25 millimeters per second, and the calibration marker is set at 1 millivolt or 10 millimeters. The paper speed, as I said, if it's set at 25 millimeters per second, then every small square is equal to 0.04 of a second, or 40 milliseconds. And every large square then is equal to 0.20 of a second, or 200 milliseconds. Have a look at the rhythm strip below. The 25 millimeters per second is highlighted there. If you've got it set correctly as well, your calibration marker, then every small square is equal to 0.1 of a millivolt or 1 millimeter. Every large square is equal to 0.5 of a millivolt or 5 millimeters. Both of them allow you to navigate through the ECG with confidence that it has been recorded correctly. Have a look at the ECG paper again below. Have a look there. You've got 10 millimeters or 1 millivolt. And there's your calibration marker at the beginning of the ECG complex. So calibration marker settings are normally set at 10 millimeters or 1 millivolt. That's normal. If, for example, you've got a huge ECG because of hypertrophy of the myocardium and it's jumping off the ECG paper, then you might have to do a half standardization or marking. And that would be set at 5 millimeters equals 0.5 of a millivolt. Or, look, it might be really, really small. And because it's a really, really, really small complex, you might double the calibration marker to 20 millimeters equals 2 millivolts so that you can see it very clearly. But have a look again at the bottom of the ECG rhythm strip. It will be labelled there. The machine will put it there for you to tell you, before you look at the ECG and interpret it, make sure that your paper speed is correct. Make sure that your calibration marker is also correct. So when we measure the ECG heart rates, you've got 6-second rhythm strip is the easiest way to do it. And the 6-second rhythm strip basically means that you've got a rhythm strip that's divided into 3-second strips. Have a look at the top of the ECG paper. You've got markers there. You've got markers there, a black line and another black line. And in between those two black lines for the 3 seconds are 15 large squares. If you multiply 15 by 0.2 seconds, you'll get 3 seconds. And if you multiply that again here, 30 by 0.20 seconds, you'll get 6 seconds. So this is an easy way for you to identify what the heart rate is in a rhythm strip. So have a look at the rhythm strip below. You've got the markers there indicated by the black arrows. And you count the number of complexes or cardiac cycles or electrical cardiac cycles in a 6-second rhythm strip. 1, 2, 3, 4, 5, 6, 7. 7 multiplied by 10 equals 70 beats per minute. This is called the times 10 method for clarification. And this can be used for irregular and regular rhythms. And it's not complex, so use it. So as I said, you just count the number of electrical cardiac cycles or ECG complexes in a 6-second rhythm strip, indicated by the black lines at the top or the superior portion of the ECG. Do not count any outside those areas, because then it will be wrong. So count the number 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 7 multiplied by 10 equals 70. Very simple. Then you've got what is called the 300 square method. And this is for normal or slower heart rates. And you count the number of big squares between two ECG complexes or electrical cardiac cycles and divide it into 300. Because there are 300 squares of 0.20 seconds in a 1-minute rhythm strip. So for example, here now, have a look. There are 5 big squares between these two complexes. 1, 2, 3, 4, 5. 5 into 300 equals 60. So the rate is approximately, it won't be exactly, but approximately 60 beats per minute. Then you've got the 1500 square method. And this is where you count the number of small squares between two ECG complexes and divide it into 1500. Why? Because the heart rates are really, really rapid. They're really, really, really fast. So therefore, if you count them, there are 1500 small squares, 0.04 seconds in a 1-minute rhythm strip. So if you divide the number of small squares, and in this case here we've got 10 small squares, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 into 1500 is 150, so the heart rate is 150 beats per minute. The the 1500 square method. And there are lots of other methods that you can use as well. I like these, but the one I like the most is the times 10 method because it's the simplest. I like simplicity. So you can review now. Let's review. Let's test you. So, what's the heart rate here? You've got a 6-second rhythm strip. Remember, the black line markers. 5, 10, 15 is a 3-second rhythm strip. 5, 10, 15 is another. So therefore, count them. 1, 2, 3, 4, 5. The heart rate should be 50 beats per minute. And the beauty of this system is that it works for irregular and regular heartbeats. Have a look at this heart rate. You've got one where they've obviously been in a supraventricular rhythm and converted back into sinus rhythm. You've got markers up there, so you count them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. What's the heart rate using the times 10 method? 150 beats per minute. Okay, you do this one. What's the heart rate? We're not looking at what the rhythm is, we're just looking at the heart rate. And remember, it's the QRS complex that gives you the cardiac output. Ventricular depolarization stimulates the ventricle to contract and pushes out the blood. 70 beats per minute. What's the heart rate? Look at the black lines, the markers. Remember, there are 15 large squares between each marker being a 3-second rhythm strip. Do not go outside that rhythm strip. 6 seconds. What's the rate? The rate is, good, 100 beats per minute. Now, let's review a systematic approach. Now, this is just using a system. We're not actually analysing anything. You analyse it at the end of a systematic approach, and this is just one approach that you can use. It's an approach I always use. Number one, I always make sure we identify the patient correctly. International Patient Safety Goal number 1. Identify the patient correctly. Patient name, date, time, age, indication, medications and clinical diagnosis. Make sure that they're right for your patient. Then you've got the right calibration, which we just discussed, and the right paper speed. And we can see at the bottom of the rhythm strip here that the right calibration is 10 millimeters equals 1 millivolt, and the right paper speed is 25 millimeters per second. So that's correct. Then you've got, what's the heart rate? You don't have to work out what the heart rate is. You just got to say, is it normal? Is it fast? Is it slow? Is it very, very fast? That's basically what you're looking at, because that will determine whether there's a problem or not. So therefore, is it slow, normal, fast, or very fast? Then what's the rhythm? You're not working out what the rhythm is, sinus rhythm, atrial rhythm. You're working out, is it regular or irregular? Because if it's regular, then you probably won't be too worried. If it's irregular, you might start getting worried. What's the electrical axis? Now remember, the electrical axis, it depends. It depends on the age of your patient. If, for example, it's the older child, I'd be looking at lead 2. If it's now the child in transition, I'd be looking at AVF. If it's now the newborn, I would be looking at lead 3. But let's say this is the older child, so the electrical axis should be positive. In lead 2, it's positive. If it's not positive, something could be wrong. It's either positive or it's negative. Negative usually means something could be wrong. Always look, is there a P wave in lead 2? There should always be a P wave in lead 2. Is it positive, negative, or missing? Is the PR interval normal? The PR interval is the interval between the P wave and the QRS complex. So therefore, is it normal, short, or prolonged? Normal is what you want. Short might mean a problem. Prolonged could indicate you've got a conduction defect. What about the QRS complex? QRS complex in lead 2 should be positive. Is it positive, narrow, wide, negative? What about the ST segment? The ST segment we said was early repolarization. And here it should be isoelectric, which means not positive, not negative. However, if it's depressed or elevated, something could be wrong. Then you look at the T wave. The T wave is later repolarization of the ventricle, and it should be positive in lead 2. So is it positive, negative, tall, flat? All these things could indicate that there could be a problem. What about the QT segment? Is the QT segment normal, short or prolonged? Because this could lead into a problem which we'll discuss when we look at certain dysrhythmias related to certain congenital anomalies, like long QT syndrome, Brugada syndrome, rarer syndromes when we look at some of the ECGs in part 4. Okay, now let's look at the criteria for the PQRST complex. The P wave, we said, represents atrial depolarization. It's a small positive deflection before the Q wave or the QRS complex. And following it is what is called the PR segment. In a child of greater than 3 years of age, which is essentially like an adult, the duration is 0.06 to 0.12 seconds. It shouldn't exceed 0.12 seconds. The amplitude isn't too big, as I said, it's small, less than 3 millimeters, but more than 1.5 millimeters, and the axis can be measured as well from 0 to plus 90 degrees. The infant, a little bit less, but the amplitude remains the same. The axis is a little bit different, as we said earlier, because they're in a stage of transition. The newborn, even less, because remember, all their heartbeats are faster the younger they get. Amplitude basically the same, and axis is right. Then we have the next component, which is called the PR interval. I prefer to call it the PQ interval, but you'll see here it's not terminology that is typically accepted. But however, in pediatrics it's very, very important because you want to be able to measure the QT interval or the PQ interval, because that can determine whether you've got a heart block situation or a QT interval situation. So the PQ or PR interval is atrial, AV node, His node depolarization, and typically in the older child it's from 0.12 to 0.20 seconds. In the infant less than 3 years of age it becomes less, because remember the heart rate is faster, and in the newborn it becomes even less. The QRS complex represents ventricular depolarization, and there's always a QRS complex, and in the child the duration is typically from 0.04 to 0.10 seconds, and the amplitude is approximately less than 25 millimeters in height. Otherwise, more than that could indicate hypertrophy. The axis, we already said, from 0 to 90 degrees. Because the child is getting younger, less than 3 years of age, it becomes less. The amplitude, however, remains the same. Anything more than 25 millimeters per 20 millimeters in height may indicate hypertrophy. Newborn, less. Height, axis, depending on what we said earlier on. Then you've got the ST segment. The ST segment we said earlier on represents early ventricular repolarization, and it's isoelectric, which means it shouldn't be positive and it shouldn't be negative above the isoelectric line. And you can look at the isoelectric line, just follow it through to your PR interval, your PR segment there. It should be aligned to that. That'll give you an idea. Or look after the T wave. That's the isoelectric line. The isoelectric line just basically means nothing's being recorded. because your big ECG can't record activity. There is activity happening there with repolarization, but this ECG cannot record it. Now, if it's not isoelectric, then it's allowed to be a little bit elevated above the isoelectric line or below the isoelectric line, but not more than 1 millimeter. And in actual fact, has to be less than 1 millimeter in amplitude. And if that's the case, it's acceptable. If not, if it's more than 1 millimeter, it's pathological, most likely. The T wave represents ventricular repolarization. And in the standard leads, it's less than 5 millimeters in height or more than 1/8 of the previous R wave, and it's got an asymmetrical shape. Have a look. It's not symmetrical. It goes up faster than it goes down. In the precordial leads, which I haven't given you, it's just double. It's allowed to be less than 10 millimeters in height. But this depends on the specific lead, V1, V2, V3, V4, V5, V6, which I'm not going to introduce here, otherwise it makes it too complicated. We'll look at that later on if you want to look at the advanced ECG, which is still in formulation. This is the QT interval, and the QT interval represents the total time for ventricular depolarization and repolarization. It begins at the Q wave and ends at the end of the T wave. And a typical, not normal, a typical duration is from 0.35 to 0.44 seconds. There's something called the QTC. The C stands for calculated, because there are algorithms that the academics or the medical experts will use to determine the QTC interval. The one that we just looked at, the QT interval, is just generic. It's a general one. This one is really, really specific, and it works out the QT interval according to a specific rate, which I haven't given you the algorithms because the rates can be anything from 60 right up to about 200. So again, I've just put here the typical duration is about from 0.35 to 0.44 seconds. If it's longer than that, you've got prolongation of the QTC interval or the QT interval, and this could indicate that there could be a problem with your infant or child or adolescent. This is called Barezet's formula, and this is one way of working out the QTC, which varies with heart rate. Now remember, in relation to age, it's not age that is applicable, it's the heart rate, unless of course you're an infant. In infancy, the experts will consider the age as well as the rate. Okay, to conclude with, we'll look at technical aspects that you might encounter when recording an ECG, whether it's just a lead or in the future when we look at advanced 12-lead ECGs. So technical problems can be related to a wandering baseline, which is just movement. I mean, if they're moving around, or you've got loose connections, or you've got the wrong electrodes connected to the leads, then you may get a wandering baseline. And this can occur with deep breathing, sighing, or movement. Then you've got muscle tremor. And muscle tremor is also referred to as somatic tremor. So basically, you might have someone who's cold, they're shivering. You might have someone with Parkinson's disease or a neuromuscular tremor, which they can't control. And if that's the case, then here you're going to have problems getting your ECG. But there are things that you can do to eliminate certain forms of artifact. The final one that we're looking at is electrical or AC interference, which means something isn't connected properly. So something isn't grounded and you need to get a technical expert, maybe a bioengineer, to come and look at the equipment and look at what the situation could be. All related to artifact. So, thanks again. Now, this is the end of part 2. If this is of any interest to you, then here, move on to part 3. See you in part 3 if you're coming.